Welcome to Ask the Expert, listeners. Welcome. It is a brand new year. It is February 2020, and I am your host, Amy Board, and we have a good episode for you today. We have a very unique guest. It's going to blow your mind, but so exciting. Not only do we have a unique guest, we are moving into a new age of Ask the Expert. We are moving into a new format. This is the first month that we are moving into our new format. So going forward, you're going to get not one, but two episodes with the same expert every month. The first episode is going to be topical. We're actually going to talk about stuff. We're going to hear some research. We're going to hear scientific background. We're going to hear the good stuff, the good scientific research-based stuff that you guys want to hear. And the second episode is going to be dropped on Thursday. It's going to be dropped the same week on Thursday. And you're going to get more of a personal flair and more of a unique personal aspect to each guest. We want you to get to know these people a little bit more. We want you to feel comfortable with some of the experts in our space. And also it gives me a chance personally to draw them out a little bit more, hear more about their personal thoughts about the topic matter, hear about their background, how they got into their field, and hopefully it'll be a chance for you guys to learn more about some of these people that are affecting our space here in the bleeding disorder community. So we're excited about it. Can't wait for you to give us feedback on how you like the new format. We'd love for you to subscribe. Go over to bloodstreammedia.com and subscribe at your favorite podcast arenas, wherever that is, iTunes or SoundCloud, whatever. We want you to subscribe to Ask the Expert and Bloodstream so you can get all of the updated information right at your fingertips. We have so much stuff coming out of Bloodstream Media this year. Oh my goodness, we have all these little extras. So if you're not a subscriber, you won't get them right away. So we want you to subscribe to the podcast. If you have questions, if you have thoughts about future podcasts, please hit me up. You can hit me up at Twitter at @Bordo87, or you can email me at mailbag@bloodstreammedia.com. So let's get to it. Let's get to our expert guest today. We have Dr. Jonathan Roberts. Dr. Roberts is an associate medical director at the Bleeding and Clotting Disorders Institute in Peoria, Illinois. He's a full-blown hematologist. He's a board certified in pediatrics and pediatric hematology oncology, and he's an assistant professor of pediatrics at the University of Illinois College at Medicine at Peoria. His research areas, which are very cool, are both in von Willebrands disease and in hemophilia. His interest in von Willebrands disease is to advance labs to basically help the diagnosis process of von Willebrands disease. And his work in hemophilia is to enhance individualized clinical management of hemophilia. He has co-authored and authored numerous peer-reviewed papers and abstract, and he has hemophilia personally. He is a very unique guest. He is a wonderful, wonderful interview. I can't wait for you to get to know Dr. Roberts a little bit more. One of his passions is about becoming an expert in your healthcare, an expert within your bleeding disorder. And how does that differ from self-advocacy? Does it differ from self-advocacy? He has wonderful thoughts. He talks about new therapies. He talks about where to actually get information if you are interested in learning a little bit more scientifically about what's happening in our treatment paradigm shift. He is a wonderful, wonderful listen. So grab yourself a cup of coffee and let's have ourselves a conversation. I am your host, Amy Board, and welcome to episode 36, or our Become an Expert episode of the Ask the Expert podcast. Tell me a little bit about your work at the Bleeding and Clotting Disorders Institute in Peoria, Illinois, and just kind of sharing your role in the bleeding disorder community, how you got involved there.
Professionally, this is the career that I had always wanted to do, to take care of patients and also do research so that I could take care of patients from kind of a personal standpoint and impact an individual patient. And then, work with the community from a research standpoint as well to help to answer some of those larger questions to impact the entire community and not just ones here in Central Illinois. And so actually, me becoming a hematologist had always been a lifelong goal. From my earliest memories, being a patient in the hemophilia treatment centers, I wanted to do this in my career. And so now my role really is as an associate medical director, associate research director, as assistant professor at the University of Illinois here in Peoria. So I do a lot of patient care. We do consults at the hospital. We see hemophilia bleeding disorder patients, other patients with clotting problems as well. as other, anemias and benign hematologic conditions. And so I do a lot of patient care in that regard. I do clinical research and some laboratory research in von Willebrand disease, and have done things in the field related to, patient-centric outcomes with the goal heme study, as well as working on developing von Willebrand assays, looking at population studies in patient-reported outcomes in hemophilia and von Willebrands disease. So I do a lot there on the research standpoint, and then a lot of advocacy here locally. We do a lot of education with our patients and education of kind of smaller rural communities in central Illinois. So Peoria is kind of the south of Chicago, kind of like the next biggest medical community. And we actually take care of patients throughout central and southern Illinois. So we go to them. We go all over, and we drive a couple hours every direction, and bring comprehensive clinic to the patients as well. So it's a pretty busy schedule, but it's every day is new and different, and that's, I think, what I really like about it.
What have been some of your takeaways from the practice lately? In your opinion, what are bleeding disorder patients struggling with, and how are they thriving?
Yeah, so I think the struggle, I think for those that are really, paying attention to all of the treatment advancements we're having, I think now we are blessed to be at a time where we're having an ever-growing plethora of choices. And so I think it can be, it's a good thing, and it can be a complex thing, right? So patients will come to us and ask, well, what treatment really should I be on? Whether it's standard half-life factor, extended half-life factor, non-factor therapies, whether or not they have an inhibitor. And so I think the great thing now is that we're able to tailor therapy really to the patient's specific needs, depending on their activity level, the things that they want to accomplish in their life, the goals that they have. And so kind of the treatment paradigm and the shift in personalization of medicine over the last decade, and really accelerating over the last few years, has been, exciting to help patients, be active decision makers in what therapies they should be on. So they're thriving in that. I think they're able to get to do a lot more. So, I grew up in the clinics where I was told, don't play basketball, you got to be really careful. And as a patient myself, I really didn't like that answer. And so I kind of worked, even back when I was a kid, back in the 80s, my family would try to help me do therapy, home therapy, so that I could do the things that I wanted to do. And so now I see patients thriving even more, in that, we're thankful that we have some patients that are, they're compliant with their therapy, they follow our recommendations, they have a good relationship with us, and they're thriving. They don't have joint disease. They're doing all kinds of activities, way more active than I was able to be when I was a kid. So we're seeing like a new generation of patients that really, if they learn how to understand and control their bleeding disorder and become their own advocate, then they're thriving in this new landscape of so many treatment options. So that's a really exciting thing.
So I'd love to hear your thoughts about, the landscape and treatment. It's changing. It's such a huge paradigm shift. What excites you? And on the tail end of that, what gives you pause about some of the new therapies that are starting to emerge in the bleeding disorder space?
Yeah, great question. I think, what I've been hearing even before I was a physician, the perfect treatment scenario would be gene therapy, right? So I think that's still in the back of my mind now as a physician, and watching the gene therapy trials emerge, and that being kind of like the holy grail of hemophilia, so that you can be cured, so you don't have to think about this anymore, that you can have a normal, quote unquote, life. I think psychologically is something that a lot of us in the field and a lot of patients in the field are kind of waiting for. Now, obviously, that's a very complex issue with lots of questions of, what type of, if we're talking about the AAV vector, which is the most advanced, what type of vector will patients be able to get? How long is it durable for? Is it going to cause any, liver inflammation, how high will the level go? Is it going to a safe level? How many years will I be cured? Will this be a lifetime thing? Can I be retreated? These are all of the questions that I think we're trying to answer right now, and I think that's kind of the most exciting. But even still, having extended half-life products where we can reduce treatment burden, have patients infuse, maybe twice a week if they have hemophilia A, but even moving towards only once a week and still having be factor VIII products is exciting for hemophilia B. Being able to infuse once a week or once every few weeks is life-changing for patients. And then some of the non-factor therapies, especially with bispecific antibodies that are on the market now and that are being developed, being able to not have to stick yourself to be able to do something subcutaneous, not have to get vascular access, especially for kiddos that we don't want to put, or that would otherwise have to have a Metaport. That can be life-changing too for families. So it's really an exciting time, but like I mentioned, it's challenging. And I think some of the other things that we need to pay attention to, especially with the non-factor therapies, when we talk about non-factor or rebalancing therapies, is are we making the blood clot a little bit too much? I mean, we've seen in the data some of the products that have come out that there's been thrombosis. Unfortunately, there's been deaths in some patients. And so we need to be careful too and think about what's the family history of an individual with a bleeding disorder? Do they have a family history in other non-bleeding disorder patients that they may have a family history of blood clots? And so do we need to be, looking for a family history of blood clots and thrombophilias, so in patients with bleeding disorders, as we look towards tailoring their therapy even further? And it also, I always talk to my patients too about other healthy lifestyle choices now. So maintaining a healthy weight, not smoking, maintaining healthy cholesterol, all those things we think about for a clotting risk as we quote unquote move towards a cure. It's kind of shifting the paradigm we have to think about as providers for our patients, and what's the most appropriate therapy? What thrombosis risk are we willing to accept as well?
Interesting that, maintaining a healthy lifestyle, has it shifted from, wanting to improve joint health to looking at some of these new therapies, or is it just, is that just a part of the conversation? There's more of a conversation about healthy lifestyle, maintaining physical activity now that we do have these products. How has that shifted in the last couple of years when you're counseling patients in the clinical setting?
So for our guys that have pre-existing joint disease, and I share that a little bit, I have some target joints, we try to help them move towards being as active as they can and preserving joint function, and maybe tailoring the different types of exercises they can do. I mean, that's why a comprehensive care team with a hemophilia treatment center is so imperative. Our physical therapist works very extensively with patients and trying to get them to be motivated. I mean, maybe they've gone decades with doing nothing because of pain, because of limited joint mobility. But now if we can get them on, some of these better therapies where we can really move towards not having any bleeds, it's got to be a patient paradigm shift within themselves to say, okay, I bled my whole life, but now I can safely do some of these activities. So let's try some stuff. Sometimes that can take a long time to get a patient to kind of come to that realization. And then I think, like I mentioned before, with the kiddos that have, thankfully, no target joints or minimal joint disease, then we can really liberalize a little bit more what they do and really focus on, okay, let's make sure that you aren't having breakthrough bleeds on your therapy. What's a regimen, a treatment burden, as it were, that you can handle as a family, and then do the activities that you want to do safely.
What have been some of the questions that well-informed patients have had in the clinical setting about new therapies? What have been some of the good questions, or what are some good questions that families should ask about these new therapies to you as a physician?
Everyone needs to become their own advocate in some form or the other, and need to ask all the questions that maybe, every provider is different. I think as a community we do a good job. My colleagues that I know across the country, trying to explain a very balanced view of the new therapies that are coming out. But patients should be asking about efficacy. So, is this going to treat my bleeds? What's the data for treating acute bleeds? What's the data for prophylaxis, prevention of bleeds? They should be asking questions about inhibitor rate, how many patients with this particular therapy are getting inhibitors, maybe associated with this therapy. They should be asking about safety. And so that goes along with inhibitors, but also with some of the non-factor therapies, having the physicians really talk objectively about, okay, what have we seen? What have the deaths been from some of these therapies? What is the thrombosis risk? How do I, as a patient, need to think about that? With gene therapy, like gene therapy trials, personally, and I've advocated this in other, national research settings and conversations with other thought leaders, that undergoing gene therapy for a patient, because it could be such a more permanent treatment, right? It maybe you get one shot and that's it. So you need to be asking those questions I mentioned earlier about, in patients that have had this therapy or what you've seen from the data thus far, how high are factor levels going? How long is it durable? How long do I have to take steroids? Do I have to take steroids at all as the gene product is, doing its thing and starting to set up shop and make factor? And then what do we know thus far of the safety data? And then it's probably going to take more than one conversation, in my opinion, with your provider, that you need to, give information to patients, let them think about it, research it themselves, and come back maybe a few times before they say, yeah, I think I'm ready for gene therapy, or I feel ready to enroll on a gene therapy trial, because it could be a more permanent type situation. So that's what I advocate my patients to do. I advocate that if they're making a change in therapy and looking to look at PK curves with their provider, pharmacokinetic curves, see how long factor's lasting in their body, and ask all those questions. You really need to be your own advocate.
That's great. I know I've done research on you, so I know you have done research to improve the diagnosis process with potential von Willebrands patients. Dr. Roberts, what has been your experience working with VWD patients and the frustration that goes into their own diagnosis?
Yeah, that is a great question. I think there's variability in even within the laboratory tests that we've used historically worldwide in von Willebrand testing. And what I always explain to patients is that von Willebrand factor it's an acute phase reactant such that it can change with different activities happening in the body. For example, if you have a recent infection, even if you're stressed with getting your blood drawn, for women, if there's variations where they're at in their monthly menstrual cycle, if you have background like autoimmune disease potentially causing inflammation, all those things can falsely elevate your von Willebrand factor level. And so we routinely will have patients come in, even for an initial screening, at least twice to ensure that we're getting an accurate baseline for what their von Willebrand levels are. But that's just, von Willebrand factor, I always tell my patients it's like Velcro for your platelets, right? So those long multimers have to grab the platelets from circulation and kind of stick them to the site of injury so that they can form a clump and aggregate and initially start the clotting process. So we typically measure the amount of protein you have. So with a von Willebrand antigen, we measure the platelet binding activity, which historically has been done by the ristocetin cofactor test. But there's a lot of variability in that test, even within your own lab and then lab from site to site across the country. And then von Willebrand factor also binds collagen, so it has different activities. And so you really need to test those different activities. And then not only that, but if we see that you could have a dysfunctional von Willebrand factor protein, then you have to send off specialized testing to other central laboratories that can take weeks to come back. So, in the assay I developed with Dr. Robert Montgomery when I was a fellow in the Blood Center, Wisconsin, was attempting to do all of those von Willebrand functional or activity tests on a single platform. And that was to kind of get at patients that have maybe dysfunctional von Willebrand factor protein. But some of the kind of the day-to-day screening that we do is, you're right. I mean, it can be frustrating because of the nature of von Willebrand factor, you need to be tested at least a few times, and that can change over time as well. So I definitely understand that it can be frustrating from a patient standpoint. But I always, tell residents that are rotating with me or when I give talks that you got to treat your patient. So if they are having some bleeding symptoms, sometimes we do things like use antifibrinolytics empirically while we're trying to come up with diagnosis, because ultimately we got to treat the patient's symptoms.
You're focused in pediatrics, so I imagine that you've witnessed several high school to college transition stories over the years, for good or bad. What is your advice to the young people that are going to college about taking ownership of their bleeding disorder? What are some steps?
Yeah, great question, and it's a challenge, because I remember being that age and kind of the feeling of finally I have freedom and I'm also invincible and I can do what I want. But you do have to remember you still have a bleeding disorder. And we know that if you neglect your health, then you could still have bad bleeds and you still have potential to have permanent joint damage or other type of deficits because you didn't take care of yourself. So I think what I tend to talk to patients when they start hitting around that 16-year-old comp visits, when they're in around 16, 17 years old, and we start talking more about what are your plans after high school and where are you going to go. We have our social worker very involved, talk about what's your insurance going to be, because we know our therapies are so expensive. And then we talk about the practical nature of it, like, okay, well, you're gone at college, you're going to have to let us know when you need factor. Mom and dad, if they've been the ones that have been instrumental in working towards keeping you on your therapy, they're not going to be there anymore. So you really need to take ownership and treat yourself, because you don't want to end up with long-term negative consequences of having a bleeding disorder because you didn't treat it. We also work really closely. We'll do in-services. We'll have our staff from our HTCs go whenever they can, either in person or over the phone, and talk to medical staff wherever the patient is, and let them know what to look out for, and so they can have a local kind of advocate for themselves as well. But it's a lot to navigate, and really it's got to be something that the patient making that transition needs to, again, learn how to become their own advocate. And we as an HTC frequently will do follow-up phone calls, when they've made that transition, how's it going? Are there reminders and kind of pep talks along the way as they start to become independent?
Talking about that advocacy, that self-advocacy, one of your passions, as we have begun talking, is to guide patients towards becoming an expert in their healthcare. And we use the term self-advocacy kind of all the time, but becoming a quote-unquote expert rings a bit different for me. And so I'd love to get your thoughts on what's the difference between becoming a self-advocate and truly becoming an expert within your healthcare, within your bleeding disorder, if there is a difference.
So not everyone has to love science as much as I do. So I obviously took it from a patient perspective and said, I have to control this, so I'm going to learn everything I can about it. So that would be kind of becoming your own expert to the max, I would guess. But being a self-advocate, I would say, is you need to know the basics of I think it's on the providers to educate patients to at least understand a high-level understanding of what's wrong in their blood that is causing them symptoms, and what the urgent treatment looks like, and what kind of the preventative treatment looks like. So every patient needs to know that. Every patient should be taught how to communicate with like emergency room personnel, or be prepared for an emergency. So that's what I think of, like being your own self-advocate, being able to talk with coaches about, my child has a bleeding disorder and here's the activities they can do. That kind of stuff everyone needs to learn. And then I think, kind of the expertise comes along with how interested an individual is in learning the nuances of the bleeding disorders, and then, doing things like, your group is doing, and becoming experts in the field in every arena, right? Your group is working towards bringing advocacy on a national, international level, doing pieces showing underrepresented populations across the globe. And there's people can get involved in their local chapters, get involved in NHF, WFH, and really become an expert in multiple realms in the bleeding disorder community. So it doesn't just have to be the science. Mental health is important. Being able to stay healthy and active and fit is important. Reaching out to the youth is important. Reaching out to the more advanced in years is important, and really having a multidisciplinary community. So I think, to me, becoming an expert is when patients take that next step and they start really putting themselves out there and bringing the conversation to not just help themselves, but to help the community.
This next question popped up in my head. I didn't write it down, so I might ramble. So I apologize in advance. For a patient that's interested, that wants to, as you said, get a higher level of understanding of what's wrong in their blood, to understand on a scientific level of what's going on, what are the resources? Where would you steer them? I know there's a plethora of resources, and there's also data and research from our pharmaceutical partners. Where should people go? Who do you trust? How can you navigate through the weeds of some of the resources that are available?
I would start with your local community. So my opinion is that every patient with a bleeding disorder should be at a hemophilia treatment center or bleeding disorder center of excellence. We have data to show that patients do better when they're there. So if you're not at an HTC, and that's with any bleeding disorder. So they're called hemophilia treatment centers, but any type of bleeding disorder, you need to get there. So that's step one. The HTC should be helping to answer all of those questions and to objectively help you navigate some of those questions about learning at a deeper level. Then I think also the local patient chapters in the state, and then ultimately moving to the NHF, how involved they want to get. The pharmaceutical companies definitely are vital partners in this, but I always hesitate to direct patients to directly talk to pharmaceutical companies in regards to getting an unbiased opinion of what therapy they should be on. That should be something with their provider directly. And I know there's lots of arenas where patients have contact with pharmaceutical companies. So I think as long as it's happening, it's not bad if they provide information, but the patient should really look to their HTC and their local communities for some of that advice.
That's great advice. I guess you see it in and out every day, but being a part of the chronic disease community, the hemophilia community in particular, is very well read and has a higher level of understanding of all of these different components going on. Why is it so critical to become even more of an expert, in particular with your healthcare and bleeding disorder, now as we're starting to face this paradigm shift in treatment?
Well, I think because there's going to be a lot of voices telling you that their treatment option is the best, right? You're going to hear a lot of people saying oh, you need to be on this particular, medicine because look at our data, it's going to be the best for you. And there's, when I was a kid, it was give me safe factor. I don't need a viral infection that could potentially end my life. I need safe factor. And people rapidly, the pharmaceutical companies rapidly responded to that. The research community rapidly responded to that, saved a bunch of lives, and helped the entire community. And that was a huge win and a great partnership. So I'm not downplaying that at all. But as we move into all these nuances of therapy and, this product has this prolongation, this half-life, this product is subcutaneous and not an IV stick anymore. This product, we may be able to cure you. Everyone's going to be saying that, come look at my product and let's use it. So really the patients are going to have to really develop those conversations more and more with HTCs, and we as the HTCs have to be on the front lines, talking to our patients and educating them about all of these options, because we should be the ones that they're hearing this information from first, honestly.
Absolutely. Dr. Roberts, thank you. Thank you for your expertise and wisdom. I would like to hear a little bit about how you became a young man with hemophilia into a science nerd, into a physician. So would you mind hanging around so we can all get to know you more?
Yeah, sure.
Woohoo! Listeners, be on the lookout for part 2 of Dr. Roberts' Ask the Expert, dropping this Thursday, where we will get to hear his personal story of growing up with hemophilia and how that inspired him to become a physician. So we'll see you on Thursday, everybody.